Hello, my name is Pamela Block, and I'm the Executive Director of the Association for the Bladder Exstrophy Community. I'd like to thank all of you who have joined our presentation tonight. I know we still have registrations coming in, and if you've just registered, you'll be getting a link shortly to join us. We are now being joined by over 90 parents, patients, and medical professionals from around the United States, Qatar, Lithuania, the United Kingdom, New Zealand, Sweden, Australia, India, Canada, and Saudi Arabia. We're here to discuss failed primary closures, the challenges, management, and prevention. It is my immense pleasure to introduce Dr. John Gearhart from Johns Hopkins Children's Center, who will be our keynote presenter tonight. For the next 30 or so minutes, he will be giving you a presentation on the topic of failed primary closures. And at the conclusion of the presentation, we will be joined in our studio by ABC's founder, Dr. Kathleen Niezgoda. At this time, you'll be able to call in and pose your questions or comments and just have a conversation with myself, Dr. Gearhart, and Dr. Niezgoda. And without further ado, I would like to turn it over to Dr. John Gearhart.
Well, thank you for that very kind introduction. I'm John Gearhart. I'm the Robert Jeffs Professor in Chief of Pediatric Urology at the Johns Hopkins Hospital. We follow 1,278 patients with bladder exstrophy and see about 15 to 20 new patients with exstrophy a year, of whom half are failed primary closures, and that is going to make up the majority and the bulk of my presentation to your group this evening. Well, why is the success of a primary closure so important? Well, we've written about this in the past, and the bottom line is if the first closure fails, only 60% of patients with a successful second closure will get an adequate capacity for a bladder neck reconstruction, and only half of those will ever be dry by voiding from below. So the bottom line is if the first closure fails, that baby is destined to have less than a 30% chance to ever be dry from below and urinate like the rest of us. If a second closure fails, less than 20% will ever be dry and urinate from below. So a failed closure is a very, very bad happening for a young child who undergoes a primary bladder closure. Well, why do closures fail? Well, they fail for a number of reasons. Certainly one is technical misadventure. You may have a surgeon who's closed one exstrophy when they were a fellow, and now they're presented in a children's hospital having to do one by themselves. Maybe they're not terribly experienced with this. That's one reason the closure fails. Another reason that closure fails, they get a wound infection. All these patients are treated with broad-spectrum antibiotics before, during, and after surgery, but less than 5% can get a wound infection. But if they get a wound infection, the wound can open and the bladder can extrude again from the body. If you don't control these babies' pain and their bladder spasms from the indwelling tubes in their bladder, this can cause the bladder to reemerge on the abdominal wall. Movement. They have to be kept still. Their pelvic bones have to remain in apposition. They can't be jerking their legs and their hips around the bed. This can cause the pelvic bones to separate that you've sewn together, and this can cause a failure of the exstrophy closure. Inadequate mobilization. That's part and parcel with movement control. The lower extremities and the pelvis has to be mobilized so the pelvic bones and the soft tissues have an adequate time to heal. And lastly, improper tube management. This bladder wound, this abdominal wound has to be kept dry. There are tubes that go up to the kidneys. There's a tube that goes into the bladder. These have to drain the bladder adequately so no urine leaks through the bladder wall, so no urine leaks through the abdominal closure, no urine leaks through the skin of the abdomen. If so, you're at high risk for getting a failed bladder closure. Well, how do you prevent failures? Well, first of all, you need a group of people who are dedicated to the treatment of these children. and this often happens when you have a center of excellence. You need a pediatric pain team and pediatric anesthesia doctors who can place catheters in the spinal canal during the surgery so that they don't have to have as much anesthesia, but more importantly, that they can deliver narcotics, various drugs to the baby after surgery or the young child after surgery to relieve their pain. You need an experienced pediatric orthopedic surgeon who knows how to do an osteotomy, who knows how to apply a fixator, who knows how to apply traction so that indeed that child can be kept immobile and the bones have time to heal while the bladder and the soft tissues are healing. You need specialty nurses. You need nurses who this is not their first day on the job and they're used to nursing and taking care of exstrophy patients. You need experienced surgeons, not a surgeon who does one exstrophy or two exstrophies a year. You need a surgeon who's comfortable with all phases of the exstrophy reconstruction. Broad spectrum antibiotics to prevent infection, pain, and bladder spasm control are important. As I mentioned with pediatric anesthesia, you need tunnel epidural catheters, which can be left in for 2 to 3 weeks to keep the baby's pain under control, to keep the baby's movement under control, and help with the healing process as time goes by. Fixation of the lower extremities and the pelvis, terribly important. This is where your pediatric orthopedic surgeon comes in. Excellent pain control. This is where your pediatric pain team comes in. And good, adequate, constant drainage that's monitored very often by the nursing staff. Well, failures can occur in several ways, and we'll try to go through each one. Prolapse of the bladder. This typically means at the time of surgery, the bladder outlet, the urethra, was not made tight enough, the pubic bones were not brought together, or there's movement of the pelvic bones, and the bladder outlet opens, and the bladder just pushes itself out through this opening. And I'll show you some pictures of that in just a moment. This usually happens early on, usually in around the first month after closure. Dehiscence, which is the worst possible complication you can have with a closure, usually comes from a closure under tension. Maybe the child should have had an osteotomy and they didn't. Maybe their movement and pain wasn't well controlled. Maybe they got a wound infection. But dehiscence usually happens early on, usually within 2 to 4 weeks after a primary closure. Other types of closure failures, you can make the outlet of the bladder, the urethra, the bladder neck too tight. This can come from using skin flaps. It can come from the stitch that sews the pubic bones together, eroding into the urethra, causing a stricture. This causes an obstruction. It increases the pressure in the bladder, which increases the pressure in the ureters, which then increases the pressure in the kidneys, and this can cause real trouble as far as bladder growth, and this really constitutes a failed closure also. If you do get stricture and it causes decompensation of the bladder, the ureters, and the kidneys, the results of this are just as bad as if the bladder came out on its own. So a stricture or bladder outlet obstruction can be a real problem going forward after the closure of bladder exstrophy. Dr. Eric Masani, who's now practicing at Akron Children's Hospital in Akron, Ohio, when he was with us, looked at vesicocutaneous fistulas. This is where the bladder is not placed down deep in the pelvis. The pelvic bones may separate a little bit, and you can get a fistula or a communication between the bladder and the lower abdominal wall. This usually means the pubic bones have separated, the bladder has come anterior and assumed a subcutaneous position, not down deep in the pelvis where you placed it. And if you have a leak from the bladder to the skin after a primary closure, that also may constitute a failure of the primary bladder closure. So just some x-ray diagrams to show you what I mean as far as an outlet obstruction or a stricture. In this picture here, you can see the bladder, which is the white structure in the middle, and those two large white tubular structures you see are the ureters. After an exstrophy closure, you should never see this much backup of urine into the kidneys. You certainly can see a little backup of urine into the kidneys, and this is called reflux. And all exstrophy children have a little low-grade reflux. But reflux of this significance, with a bladder that's that thickened and that small, often shows that you can see that narrow area below the bladder. That's a urethral stricture in a male child, and this has caused the bladder and the ureters and the kidneys significant damage. Here on the left, you see a little girl who had a dehiscence of her bladder. The entire bladder has come back out on the lower abdominal skin. This happened 2 weeks after her primary closure, secondary to a wound infection. The male child you see on the right, you can see the bladder there above the penis, that pink structure that's sticking out from the lower abdominal wall. This is 5 weeks after a primary closure. The baby was closed early, but did not have an osteotomy, had a nice big bladder, and probably wasn't closed securely enough. And now, while the penis looks terrific, you still see the bladder prolapsing above the penis, and this is a failed closure. Now, some complications that you see with primary closure can be associated with different types of exstrophy closures and repairs. In the lower left-hand corner, you can see a young child who lost the head of the penis, the glands, and the erectile body on the right side, on the left side of the penis. This came from the complete primary repair of exstrophy. And the same way on the child on the right has the worst of all worlds. He has complete dehiscence of the bladder, and he has lost the entire right half of the penis. He's lost part of the urethra, lost the glands, the corpus, and part of the entire penile structure. So these are severe complications associated with a failed closure. Here on the left, just another example of this. This is a little child. You can see the silver thing is a urethral sound. It's going in the urethra below the head of the penis. The urethra has been lost. The posterior urethra has been lost. The bladder has prolapsed out of the lower abdominal wall. And then the child on the right, again, just another example of loss of the hemiglands, the right half of the head of the penis, with a closure at birth. And if you look very carefully at the base of the penis, you'll see that pink structure pooching out a little bit at the base of the penis. This child also has a bladder prolapse. So this child has lost the right glands, he has got a bladder prolapse, and this is a failed closure. With the penile disassembly technique, the CPRE, the Kelly repair, which our colleagues in England and some of our colleagues in Australia use, the rates of failure are just the same as any other type of epispadis, of any other type of extra repair. But penile complications are serious and difficult to repair, and these require oftentimes a multidisciplinary team, pediatric plastic surgeons, etc., as these are going to be complications that are very difficult to deal with in early childhood and the teen years. So as we said, failures occur for a lot of reasons. One reason that failures occur is improper patient selection. The bladder template at birth may be too small to close. The surgeon may be anxious to put the bladder back inside the body, but sometimes the bladder are so small or of such poor quality that it's probably not the right thing to do to close them at birth or in the newborn period, and one should wait, give the bladder a chance to grow, see how it does, and then close it later on with an osteotomy. It may be a nice sized bladder, but the pubic bones may be widely separated, and the surgeon may try to close it without an osteotomy. This is something we do. We bring the orthopedic surgeon to the operating room with us, Dr. Sponseller. We examine the child carefully together in the newborn period, and if Dr. Sponseller and I are in agreement that we can bring the pelvic bones together without an osteotomy, we'll do it. We feel comfortable doing that. If there's any doubt in our mind, though, about the ability to close this bladder securely without an osteotomy, then we go ahead right at that moment, do an osteotomy, and then proceed with the bladder closure. Technical errors can cause a failure to occur. Inadequate mobilization of the bladder and the bladder neck. I reclose about 8 to 10 exstrophies a year, and it never fails that when you get down deep in the pelvis, the ligaments, fascia, things which should have been cut to allow the bladder to descend into the pelvis, oftentimes those fibers are virginal and they've never been touched, so it was an inadequate closure and they didn't get the bladder down deep in the pelvis where it belongs. Or if it's a nice bladder, as I said above, too much tension, you close it without an osteotomy, you're putting the child at risk for a failure. And lastly, wound infection. Everybody gets broad spectrum antibiotics. Wound infections can still occur, and you can get a prolapse or even a dehiscence with a wound infection. Premature tube displacement, as we said, this can promote a failure. The ureteral stents can come out prematurely. The suprapubic tube come out prematurely. The nasogastric tube can come out prematurely. The baby's abdomen gets distended. This puts excessive pressure on your bladder, and the doggone thing opens up again. Inadequate mobilization of the pelvis through extremities. We typically like to use an external fixation device when we do an osteotomy. If we get them early on prenatal ultrasound, we know they're coming. We're happy to close them in the early newborn period. We'll put them in modified Bryant's traction. Our luck and the luck we see of a lot of our referred patients who've had a failed closure have because they've used a spica cast or a mummy wrap. We don't think this immobilizes children enough. I have colleagues that I respect and are friends with who use spica casts and use mummy wraps in our practice, and I respect that. But in our practice, we see nothing but problems with these two types of immobilization. You have to control the child's pain. If you don't control the child's pain, the child's going to move around too much and you're going to get a failure. And you need a dedicated Exstrophy team. Nurses, pain service, surgeons, orthopedic surgeons, child life people. You need a team to take care of these people. You can't do it by yourself. As we said a moment ago, technical errors, inadequate mobilization of the bladder neck and the posterior urethra. As you see from this lovely artwork from Campbell's Urology here on the right, you can see the bladder and the bladder neck, and you can see the penis. And we're separating and dissecting these ligaments, these suspensory ligaments that connect the urethra and the prostate gland to the pubic bone. These need to be cut deeply all the way down to the area where the rectum goes through the pelvic floor. And the idea behind that is that you can then sink this down deep in the pelvis where it can heal and where it can heal in the proper fashion and be in the position of a normal bladder after it's closed. Here's a bladder here, a nice looking penis in a young newborn baby, but look at that bladder. It's small, it's covered with these polyps. This is a poor quality bladder, and if you try to close that bladder, you're prone to failure. And if a failure occurs in a small, poor quality bladder, the chance of that bladder ever growing after a second closure and being of benefit to that child is really very slim. So when you see a bladder like this, you need to just back off, give the child 6 months to a year to see if this bladder smooths out, see if it gets bigger, and hopefully the child could undergo a delayed primary closure. So if you don't get the bladder down deep in the pelvis, and if you don't dissect the bladder neck and posterior urethra down deep in the pelvis, you're going to see something like this. This is a child who was transferred to us a couple of years ago. About a week after a closure, the baby was closed without an osteotomy, which was fine. Was immobilized, but got a wound infection. The bladder and posterior urethra had not been placed down deep in the pelvis. And you can see here, even with a superficial wound infection, that pink thing you see in the middle of the wound is the bladder. And the bladder has already begun to extrude itself only a week after a primary closure. Closures with tension, this is another reason you can get a failed closure. This is why you have to have a good orthopedic surgeon who works in a collaborative effort with you, who works hand in hand with you on a daily basis to know that you're doing the right thing for this child. An osteotomy is helpful. It lets you close the bladder, the fascia, the abdominal bones, the pelvic bones, the subQ and the skin without tension. This also helps bring, as you see the drawing on the right, it helps bring the big pelvic muscles together under the bladder neck to help support the bladder. In the female, it helps support the vagina and the uterus for later life. And we use osteotomy in a lot of patients. If they're older than 72 hours, if the pubic bones are greater than 4 centimeters in separation, that's called the diastasis, or if they've had a failed primary closure, we truly feel that osteotomy is mandatory. You can do an osteotomy with a primary closure, but it can still fail. This is a group of patients just submitted to publication by Dr. Siri Sridharu, who's a pediatric surgeon from Thailand, who's been working in the laboratory with us the last year. And she found out of 156 failed exstrophy patients in a group of patients over a 25-year period, 46 patients who were referred after their primary closure, but they still all had an osteotomy when they were referred. 43 came from outside institutions, and 3 of those were ours. The vast majority had bladder dehiscence. The whole bladder urethra opened up. 23%, almost 25%, had prolapse of the bladder at the base of the penis. 20% developed that stricture, that narrowing of the bladder outlet that we spoke about. 15% of them had a leak or a fistula between the bladder and the abdominal skin, and 15% were a complex failure. These were mainly patients who had complete primary repair of bladder exstrophy or Kelly repairs, who not only the bladder came back out, but there was significant soft tissue loss of the penis. So we did what's called a multivariate analysis, and what this basically shows is you put everything in: the age of the child, the weight of the child, whether they had an osteotomy or not, how they were immobilized, how long they were in immobilization, who the orthopedic surgeon was, so forth, so on. And then you let a statistical package tell you what was really significant. And what we found was that there were 3 major things that predicted, even though these children had an osteotomy, that indeed the closure could fail. And the 3 things that were highlighted, and you can see here, that made a difference was the kind of traction they had, okay? The immobilization time, if they were immobilized for greater than 4 weeks, that was significant. And if they had a pediatric orthopedic surgeon doing the osteotomy, they did far better than if they had an adult orthopedic surgeon doing the osteotomy. Now that makes common sense that a pediatric orthopedic surgeon is going to do a better job with a pelvic osteotomy than an adult orthopedic surgeon. But there are colleagues of ours around the country and around the world who don't have pediatric orthopedic surgeons who specialize in looking at and being interested in a child with bladder exstrophy. So again, the way they're immobilized, the time of their immobilization, and the orthopedic surgeon is very important, because you can still do an osteotomy and it doesn't guarantee success. And we just talked about that a moment ago. They can have an osteotomy and it still can fail. Time of immobilization, whether they had an adult or pediatric orthopedic surgeon, all those things are important going forward to prevent failure. Even when you do an osteotomy, they still can fail. Infection, a major cause of failure in bladder exstrophy. As we mentioned, we give them broad spectrum antibiotics for 10 days after closure, and then they stay on a prophylactic antibiotic as long as those tubes are in until the tubes come out, and then they're put on a little prophylaxis for several years after that until their reflux is treated. We prep them from their nipples to their knees, from the shoulder blade to the back of the knees, front and back, so we can turn the baby from side to side when we do the osteotomy, because we do the entire operation from the front, both the osteotomy and, of course, the exstrophy closure. So this is just a paper by Kirsten Meldrum, who's the pediatric urologist in Grand Rapids, Michigan now at Michigan State University, and she just looked at 194 patients who were referred after they had their initial bladder closure elsewhere. And the bottom line was, if they had an osteotomy and they had appropriate fixation, there's a 93% success rate in their primary closure. If they didn't have an osteotomy, the success rate was less, but still reasonable if they were in the proper type of traction. If they had a primary closure and they had an osteotomy greater than 3 days, the success rate was very high with an osteotomy. Without an osteotomy, after 3 days of life, the success rate was very, very low. Now, granted, this is a very distinct group of patients. They were referred after treatment elsewhere. But again, proper immobilization, proper fixation of the pelvis increases the chance for success in a primary bladder exstrophy closure. On the left, you just see a young baby that was diagnosed prenatally. The mother came here, she delivered here. We closed the baby in the first couple of days of life. The baby did not need an osteotomy, but was hung in modified Bryden's traction for a minimum of 4 weeks. The child on the right is a little girl from Italy who had a failed primary closure. She was reclosed. She had Buck's traction. She had an external fixator for 6 weeks. If they've had a failed closure, Dr. Sponsor takes an osteotomy, picture of the osteotomy at 6 weeks. If he's happy with the healing, then all the fixating devices come off. If he's not happy with the healing, he'll wait another couple of weeks to make sure the healing of the pelvic bone is complete before we remove the fixating device and before we remove the urinary tubes. This operation has to work for the remainder of the child's life. Just to show you, here's some fixator pins and a little baby. After closure, you can see the osteotomy incision there. You can see the pins, and then 3 months after removal, you can see that there's hardly a scar. It's healed very nicely. The osteotomy incision is where the trunk of the body joins the upper leg in a crease, and these heal very well, either with a primary closure or even of a secondary closure. So we talked about another reason for failure: the tubes come out too early. We don't remove the NG tube that goes down into the tummy until total, complete bowel function has returned. The suprapubic tube and stents are sutured in to the abdominal wall and with a good tight dressing to make sure they don't come out. If a tube does come out in the early postoperative state, you take the child back to the operating room and you replace the tubes. Because if you begin leaking urine through your wound, you will lose your closure. Inadequate pain control, again, another way of causing failure. We use a tunnel epidural catheter, which you ladies who have had babies understand about epidural catheters and how well it helps control your pain during your childbirth. Well, we use this in babies, and now we can in young, even older children with failed closures, and you can leave the tunnel epidural catheter in 2 to 3 weeks easily. You can then supplement them with some intravenous narcotics around the clock if need be. They can have Valium, Ditropan, other things to control bladder spasms. But the main thing with pain control is that they're monitored in a unit where the pediatric nurses are experienced, where they can manage epidural catheters, and they understand the importance of pain control, sedation, and control of movement if you want your closure to be successful. And as I said a moment ago, you need an Exstrophy team. You need an orthopedic surgeon. You need great anesthesia. You need great pain control. You need great nurses, good smart residents who are familiar with these things. You need a good ABC pediatric parents. You need a parent support group, child life specialists, senior pediatric nurses. This is not just a surgical exercise. It's a team sport, the successful treatment of bladder exstrophy. Our colleagues in England have focused the treatment of exstrophy in 2 centers in London and Manchester. Last year they did between 17 and 20 closures in Manchester and did 3 to 5 closures in London. So they've concentrated the treatment in 2 places. We looked at 145 failed primary closures referred to our unit over the last 20 years. All were reclosed by a single surgeon, which was myself, and we saw who closed them primarily. And we thought this data was very compelling. 70 of these failed closures were closed by a fellowship-trained pediatric urologist. 24 were closed by non-fellowship-trained pediatric urologists. 16 were closed by fellowship-trained general pediatric surgeons. 20 were closed by general urologists, and 15 were closed by unknown surgeons. We know who the surgeons were for the most part, but we don't know their training. We don't know if they're fellowship trained. These were mainly from overseas, but still yet, 15 of them, we didn't know the training of the surgeon. So why could there possibly be a need for centers of excellence? Well, 50% of that 145 some odd failed primary closures were treated by non-fellowship trained pediatric urologists. But even training in a fellowship program does not guarantee success, because some fellowship programs, a young person might help treat or treat one exstrophy during their entire fellowship. And you need an exstrophy team, a senior surgeon, a junior surgeon, an exstrophy team mandatory to achieve the best outcome. As we said, the National Health Service in England has limited the treatment of exstrophy to 2 centers. In the United States, I don't think that's going to happen, but certainly the insurance companies are now taking a look at this thing, and probably will have something to say about this in the next few years. So if the closure fails, where do you start? How do you start regrouping, changing things around, and assuring yourself the second closure is going to work? This is the child I showed you a little earlier, who was referred a week after a primary closure. You can already see the bladder pooching out just under the abdominal skin. You take them to the operating room, you remove all foreign bodies, you debride or cut away any dead or devitalized tissues, you culture the wound, identify the germs, treat them with appropriate antibiotics. We do have some neat little devices that have come out in the last few years. We can actually put a sponge in this wound and put a dressing over the sponge. This will gently suck on the wound, help clean it up, help retard the growth of germs, and really help us tidy this wound up so the child can undergo a reclosure in 4 to 6 months. And of course, you need psychological support for the parents, because this is a major complication in the exstrophy pathway. So the one lesson to learn that we teach the young surgeons after they've had a failed closure is wait 4 to 6 months till you reclose them. You have to let the wound settle, all the scarring set in, all the healing occur, and this takes 4 to 6 months. Dr. Fremberger at the University of Oklahoma, when he was with us in training, looked at this in 2003 and published this in the Journal of Urology, and he found a minimum of 4 months, and more likely 6 months should elapse before you try to reclose the bladder. The bladder capacity, we'll take the child to the operating room, examine the bladder, try to measure the bladder capacity, measure the distance between the pelvic bones with Dr. Sponseller to get an idea of what we need to do going forward. All of these boys get testosterone injections 5 weeks and 2 weeks before their reclosure. This helps increase the amount of skin they have available on their penis, because sometimes we will combine the exstrophy reclosure with an epispadis repair, but you just need that extra skin. If the urethral plate is terribly scarred from the primary closure, we will actually have the patients put some testosterone cream on the urethra in order to help increase the blood supply of the urethra, soften the scarring, and make the reoperative procedure easier. If it's a little girl and she's had a failed closure, we use Premarin cream, just like menopausal ladies use to the vagina. We'll use estrogen cream on the urethra, on the female genitalia, to help improve the blood supply and, again, try to enhance the success of a second closure. So here's a little baby that had a failed closure with a prolapse. So we took the baby to the operating room. Dr. Sponseller is there. We've taken an x-ray. You can see the pelvic bones are 4 centimeters apart. You can see that there's a prolapse of the bladder, not a complete dehiscence. You see grade 2 reflux on the right, a little bit of grade 2 low-grade reflux on the left. The diastasis of the pelvis is 4 centimeters. So this child's going to get reclosed with an osteotomy as soon as things settle and the child's ready for a reoperative repair. If they've had an osteotomy at the primary closure, or if they have an exceedingly wide pubic diastasis, sometimes Dr. Sponseller will want a 3D CT to help plan the osteotomy, especially if they've had a previous osteotomy and a failed closure. Dr. Carlo and I have been now in 35 patients. We begin using 3D MRIs to guide our dissection of the pelvic floor, to make sure that we're doing a good incision, to make sure we're doing a secure incision. And this has become very, very helpful in children with failed exstrophies, because it shows you some areas where your dissection needs to proceed. It enhances the safety of the operation when you have a 3D MRI looking at the child in 3 dimensions while you're operating. So if the bladder is of good quality and the urethra is of good quality, we'll reclose them with some testosterone stimulation and do an epispadias repair at the same time. In the off chance that the bladder is of terribly poor quality or the urethra is of poor quality, occasionally we'll excise the bladder, give them a colon conduit, and then repair the penis at the same time. That again is the minority of failed closures. Most failed closures can be reclosed with an osteotomy. We see some children from third world countries who come, they're 6 or 8 years old, their bladder has failed, it's back out on the surface of the body. And those kind of children, we'll augment the bladder, close the bladder, give them a continent urinary stoma, and repair the penis all at the same time. Our colleague Philip Ransley in London has written about that, and we have written about that too. And that's a good way to handle a failed closure in an older child, but not a new young baby. So reclosure of a failed exstrophy requires some planning. Preoperative planning as far as the bones, how wide they are, the status of the hips, those kind of things. Soft tissue planning. How's the urethra? Is it of good quality? Is it of poor quality? If you see that dehiscence of the bladder in that baby there on the left, nice sized penis and a very nice bladder. So that's a patient who's going to be ideal for a second closure. If the urethra plate is damaged or it's lost, we'll close the bladder, put a graft of a buccal mucosa graft on the urethra, and then come back and close the urethra 6 months later. If the urethral plate's intact, as the patient on the right you see who had bladder prolapse, we'll both close the bladder and do the epispadias repair at the same time. If there's a shortage of penile skin and we're going to reclose them, and if we're planning on doing the epispadias repair at the same time, we'll have our plastic surgery colleague, Dr. Rick Redette, come in, put a tissue expander under the skin of the penis, gradually inflate that over 6 to 8 weeks, bring the baby back, do an osteotomy, close the bladder, close the urethra, and then use this expanded skin to do an epispadias repair. So there's lots of tricks you can use in this business when you see an adequate volume of these patients. Reclosure of an exstrophy requires traction, certainly for 6 weeks in a failed closure. If we do the urethra at the same time, we'll leave a urethral stent in for 2 to 4 weeks to drain the urethra and let the urethra heal around that during the period of bladder healing also. Suprapubic tube and stents are left in as long as they're in traction. When Dr. Sponsor takes them out of traction, takes the fixating device off, then we begin removing the ureteral stents, clamping the SP tube, letting the child drain urine from below. So other than really prolonged traction and leaving the tubes in a little longer, the management of a failed closure is pretty much the same as that of a primary exstrophy closure in the first year of life. So the post-operative management of a failed closure, you need to think about several things. Superb pain and movement controlled, epidural catheter for 3 to 4 weeks, fixation for 6 to 8 weeks. As I said, Dr. Sponsor will do an x-ray at 6 weeks. If the hip pelvic bones have healed nicely, he'll remove the fixating device. If he's not happy with that, he'll continue with the traction and the fixation for another couple of weeks. They have child life people playing with the child, entertaining the child, helping the child, and of course the parents need to live in. Kathleen Niezgoda, whose husband Jeff Niezgoda founded the ABC many years ago. Part of her master's degree program, she got interested in what the cost was of a failed exstrophy closure. And this is some data from some early data from Kathleen Niezgoda years ago, which showed a failed closure. First failed closure, about $140,000. Second failed closure, $180,000. Third failed closure, $230,000. Now, the first failed closure includes the first closure which failed, plus the successful second closure, total of $140,000. Christopher Hesch, who's a medical economist here at Johns Hopkins and a colleague, published this in the Journal of Pediatric Surgery last year, and he looked at 162 classic bladder exstrophy patients who were closed from 1993 to 2013. 62 of these were failed primary closures, 59 were referred, 3 were ours, plus 100 successful closures, all who were treated here. He looked at length of stay, number of inpatient admissions, days since the start of the study, whether an osteotomy was used or not, and having a failed primary closure at a minimum adds $20,000 to your hospital bill, counting the first and second closures. The inpatient hospital charges were increased by $8,400. Professional fees were almost $12,000 more. Osteotomy, what we thought was very interesting, did not negatively impact the overall cost of treatment in the year following and including reclosure. So an osteotomy really confers some degree of protection, and really probably with a successful closure, utilizing an osteotomy cuts healthcare costs. So in conclusion, a failed exstrophy closure is a major complication. A successful primary closure is still the single most important predictor of eventual urinary continence. One failed closure, a good successful second closure, that child still has less than a 30% chance of being dry. 2 failed closures, a successful third closure, that child has less than a 20% chance of ever voiding from below and being dry. And a third failed closure, that child is destined for failure. Reclosure can be successful in the majority of patients, utilizing standardized techniques. You have to have a reasonable bladder size and capacity. The surgeon carefully selects the patients for reclosure. You have a team of experienced surgeons who are used to doing operations like this, an exstrophy team including pain control, anesthesia, nursing, child life, and a center of excellence that's dedicated to the treatment of these children. So what are the goals of failed exstrophy closure? Well, the real goal is to prevent failure. We want to increase continence rates in these children. We want to decrease the need for bladder augmentation and improve the cosmetic results of these children, and most importantly, to improve their quality of life. And what we all want at the end of the day is happy children, just like these 4 boys who were closed over a period of a long weekend once a few years ago, all underwent closure, and they're good buddies and good friends, and now they're growing up together. So we're happy here in a minute. We'll take a couple-minute break, and then I'm happy to entertain any questions from the audience regarding the failed bladder exstrophy closure. Thank you very much.
Well, good evening, everybody. That was a fabulous presentation. Dr. Gearhart, thank you so much for taking some time and walking us through what can potentially be a disaster for a child born with bladder exstrophy, and that's a failed initial closure. And I want to thank you so much for joining us tonight, and say hello to Pam as well. Pam, how are you doing tonight?
I'm great, Jeff. Thank you. Thank you again to you and your team for putting on these very, very insightful educational webinars for the exstrophy community. We very much appreciate all of your work and support around this.
It's our pleasure to do that, and yeah, thank you very much, guys, everybody working in the background. In fact, one of the guys working in the background, Dr. Gearhart, is someone you might know, my son Jeffrey. And you know, I was listening to the presentation, and that brought back a lot of memories. 27 years ago, nearly 27 years ago, this July, we first made the acquaintance in Baltimore, and I think it was the wee hours of a morning, I think on a Saturday morning.
Well, I remember you were still in the Air Force, and I remember one of our great Hopkins guys was an orthopedic surgeon at Travis Air Force Base, and he guided you to us, and what was a physician treatment became a 27-year friendship.
Yes, it really is, and we're very fortunate to have found you and Johns Hopkins, and I know Jeffrey. I'm speaking for Jeffrey when I say that. But I probably bet you never thought 27 years ago when we met that we'd be talking again about bladder exstrophy, and it goes quickly, doesn't it?
It goes way too fast, Jeff.
Well, you know, before we get to the Q&A, and I would encourage all the listeners to either send us your questions or give us a call on the phone and talk to Dr. Gearhart live. You can see the number listed there on the screen. You know, it's interesting. I've heard a version of this presentation many times over the years at the bladder exstrophy picnics and Johns Hopkins, where this organization was actually born. And then through the years with the ABC picnics and gatherings. And, you know, I want to applaud you for a couple of things. I think the first thing I'd like to applaud you for is, you know, your commitment to excellence. And I think the Centers of Excellence topics really hits that right on the head. Because I really believe that, you know, these children need to be managed in an excellent fashion to have the best outcomes. But the other thing that I wanted to compliment you on is, you know, all of your slides continue to be updated. You continue to refresh the slides, and many of the publications are 2015, 2016. We're not talking about the past. This is really current literature and current information.
Well, it is, Jeff, and we have a great research team of bright young people, like the health economist who worked with us and kind of embellished Kathleen's work from many years ago. And, you know, the idea is to make discoveries and to continue to improve the quality of life in these children.
Yeah, that's absolutely right. Well, we got a few minutes here waiting for our questions to come in. I'm sure that, don't be shy out there. Pam, I just want to provide you the opportunity. I understand we have a big event coming up in July in Oklahoma City. You want to talk a little bit about that?
Sure, yes. We are hosting another ABC conference in July 8th, 9th, and 10th. This year, Oklahoma Children's Hospital has graciously offered their site to host the conference this year. And as you know, that it is our 25th anniversary coming up in June, so we're very excited to not only be meeting new families and young families, but really a lot of the families with grown children are coming in, and adult patients are coming to just share their insights and their journey that they've had with Exstrophy. And I know Dr. Gearhart will be there. Some of the doctors that have been around and really have committed their life's work to helping these children have a better quality of life will all be celebrating in Oklahoma City this summer. So there's still time to register. We've got a couple of surprises that we'll be unveiling at this year's conference. So if anybody has an opportunity, if you haven't made your plans yet, we'd love to have you join us there.
Yeah, absolutely. Look forward to seeing you all there. I've got a couple comments to make on the conference myself, but before we do that, we're going to take this call. Aline from Nebraska is on the line. Hello, Aline.
Yes, hello. My name is Eileen.
Oh, I'm sorry, Eileen.
And that's okay. You know, we have a daughter who is almost 5 years old, and at the time of her birth, she went to Kansas City for her first surgery. And at the time, the doctor tried to he was explaining that he was doing like 2 or 3 steps at a time to do the primary closure, and the second step was that, like, closing her bones or pubic bones, but it didn't quite work. Like, her pubic bones pulled back away or apart, I guess is how it worked. And we never quite understood what happened or why he was trying to do a couple steps at a time. I wonder if you could say something about that.
Well, generally speaking, you try to do the bony surgery along with the soft tissue surgery, because when you get the pelvis nicely fixated, you stabilize your soft tissue repair. He may have not had an orthopedic surgeon available to do a good osteotomy for him at the time, and thought maybe if he got it early, he could mold the pubic bones and bring them together, you know, without having to do an osteotomy. But then it may have separated a bit, and he said, okay, I really realize I need to relax this wound, decrease the tension, do an osteotomy, and go back and close her. But that's a real complication, and it's a worry. And the real worry is, will this little bladder ever grow and be of benefit to this little girl going forward?
Right. And actually, at this time, her bladder really is not growing as much as he had hoped. And so we don't know.
Right. If you, the data we showed that Colonel Novak, the Army surgeon down in San Antonio, the work he did when he was with us, 130 some odd reclosures. If the first closure fails, it really portends a very bad future for this bladder as far as growth and the ability to have a bladder neck reconstruction and to be able to urinate below like the rest of us. And so this is why we really stress, if you don't do a lot of these, maybe you shouldn't do them. And if you do them, do it in the same way every time and get excellent results. And you can really, and with all the scientific data and things we do with 3D MRIs today, still the two most important factors in a newborn to be able to predict to young parents the child's ability to void and be dry 5 to 6 years from now is the size of the bladder template at birth and a successful primary closure.
Mm-hmm. Okay, thank you.
Yes, ma'am.
Did that answer your question?
It does. It does. Yeah.
Well, thanks for joining us tonight. We appreciate the phone call.
It was a good seminar. Thank you.
We have another call, Dr. Gearhart. Tricia from Minnesota is on the line. Hello, Tricia. How are you tonight? Tricia?
Yes, hi.
Hi, how are you? You're on the line with Dr. Gearhart.
Okay, great. Good evening. My daughter is 9 months old, and we will be having her closure in July at Mayo. And one of our biggest worries is she has lumbar syndrome. And so, of course, the bladder exstrophy is part of that. Due to the lumbar syndrome, she cannot be in traction. So I believe the pediatric orthopedist route of recovery is the X-Fix, the external fixator.
Yes.
With everything she has going on, is there any words of advice regarding the X-Fix? Our orthopedist mentioned another alternative possibly, but because of the lumbar syndrome, there's so many variables that we always have to be conscious of. Wondering if you have any advice on that.
We're very pro-external fixators. It really does a nice job. In a child her age, it's going to be easy for them to get a couple of good pins above and a couple of good pins below and apply the fixator. And it will really stabilize the pelvis and aid healing. And a good orthopedic surgeon who's familiar with putting fixator pins in and applying a fixator device, she should do very well with that.
Okay. As far as size, I know that was their biggest worry, was waiting until she was a year. We've been waiting for this for almost a year now. For the pins, she is small in size. Does small stature have any complications along with it for the X-Fix?
Well, that was a very smart judgment. Now, I'm not Paul Sponseller, and I'm not an orthopedic surgeon, but I'll tell you what Dr. Sponseller has taught me over the last 28 years, and that is this, is that, the bone is really soft when you're born, and so, and especially in a child who's more demure, and what your orthopedic surgeon was waiting on was for the bones to get harder so that when he does put those pins in there, that they will stay in place, because the bone will seal around the screw at the end of the pin. So that was a very smart move, waiting till she was older so that you can get a better fixation. And that adds to the safety of the repair.
Okay. And regarding any infection, we dealt with a dehiscence in a previous surgery she's had for a tethered cord. What are the first signs of that when dealing with neck fix?
Well, a really good, they need to douche the vagina. They need to prep the tummy from the nipples down to the knees, front and back. They will give her some really good broad spectrum antibiotics to try for at least 10 days or so to convert a contaminated wound into a clean wound. And they will then give her some oral antibiotics for as long as she has any drainage tubes in. So the infection rate's low. It's less than 5%. But again, they'll take care of that. And we have some wonderful antibiotics these days. As far as a wound infection, wounds infections usually come 5 to 7 days after any kind, whether it's a hernia or a gallbladder or an exstrophy closure. You typically see signs of a wound infection, if you're going to get one, within 5 to 7 days after the primary surgery.
Okay. And my very last question is, kids with X-fix apparatuses, how long are they in the hospital before they are sent home?
Well, we're very conservative with that, and we will keep them in the hospital for 4 weeks. Our sponsor will take an x-ray at 4 weeks. If he's happy that the hip bones where he has cut them have healed nicely, he'll remove the external fixator and will send the child home in 2 or 3 days. So the insurance companies used to balk at this, but now that we have data showing them, first from Mrs. Niezgoda and now from our health economist, that show us what a failed closure really costs, the insurance companies are a lot more receptive to keeping the child in the hospital for a few weeks.
Okay, wonderful. Thank you.
Yes, ma'am.
Tricia, thank you so much for that call, and good luck to you. I know this is a little bit off topic, John, but I'm going to go ahead and ask the question. You know, you had mentioned in your presentation negative pressure wound therapy, and being a wound care guy, I sort of can relate to that. How about the newer technologies that are available, like the post-incision Provena? Are you using any of that technology?
We've used that in concert, Jeff, with some of our plastic surgeons, and especially in some of the cloacal exstrophies where the wounds are just so large, so very large. We've used those, and we've used that in combination with the VAC device, which I think is a gift from the gods.
I agree.
Oh.
That's interesting. That's good. You know, Tricia, the other thing I would recommend is investigate a product called hypochlorous, HYPO, hypochlorous acid for pin site care. It's probably one of the best things out there on the market, but I'm sure your medical team is aware of that and will take good care of you. We have another caller on the line. Is Karen still on the line, guys?
Yes, I am. I'm here.
Karen from Pennsylvania, thanks for joining us tonight. You're live with Dr. Gearhart and Pamela Block.
Thank you. Hi. First of all, it's an excellent webinar. But you showed a lot of boys with bladder exstrophy. I too have a granddaughter. She's 15 now. The statistics, boys to girls, and I want to know: can you see this in sonograms prior? Because they never saw this when she was, until she was born.
So the answer is it's a two-part answer. Yes, they're getting better at diagnosing these prenatally. They really are. A fetus voids about every 90 minutes during fetal life. And if they scan a fetus and they don't see any urine in the bladder, then they should have mom go out and get a cup of coffee and go have lunch or whatever, come back in 90 minutes and re-scan her. And if they see fluid in the bladder then they know things are fine. But if they scan her another 90 minutes later and there's still no urine in the bladder, a little light should go on in their mind and they should say, whoops, well, maybe we have an exstrophy. And it also depends on where in the pregnancy they scan them. But as the pregnancy proceeds, as the colon gets bigger, the small bowel gets bigger, the liver and all the internal organs get bigger, the bladder pooches out more onto the lower abdominal wall and they can see it better. But even today with 3D ultrasounds and really good people, they still miss it probably 40% of the time on prenatal evaluation.
Okay.
Did
and what about the statistics from boys to girls?
Yeah, it's probably 2 to 3 to 1 boys to girls. They have trouble sexing the babies because in the boy, the penis is somewhat shortened and wide, and it's somewhat tucked up against their abdominal wall. so they don't really see it very well. And sometimes they'll make the diagnosis of exstrophy, but they'll miss the sex of the baby. But again, it's still missed probably 40% of the time. But it's about in our practice and in the literature, about 3 to 1 boys to girls.
Okay, and as they get older, does the scar tissue at all? Because my granddaughter's, that's all like exposed. There's no lips on the vagina. Her clitoris is very large.
Mm-hmm.
And
so they have the genitalia in girls is very, very variable. The labia minora, the small lips of the vagina, oftentimes are very small. They'll typically have a small hemiclitoris on one side and a small hemiclitoris on the other side. But sometimes one labia minora will be large, one will be small, but generally speaking, most are small. The labia minora has no sexual function, so it won't harm her ability for orgasm and other sexual functions at all. And we've looked at orgasmic function in older girls with bladder exstrophy, and it's really very, very acceptable.
Oh, okay. And what about the scar? That's what I wanted to know. The scar, does that like adhere to anything inside, like the scar tissue? Do you understand what I'm asking? She just says that her scar hurts her all the time, and we wonder if it's pulling or...
Well, scars mature, and what a lot of people don't realize about the biology of wound healing is it takes a scar a good 4 to 6 months to even settle out a little bit, and it can take it a year or two to mature completely. So I wouldn't be surprised if she complains of a little discomfort, but if it gets to be a persistent thing, then certainly your consultant, they should talk to their consultant surgeon about it and get his or her opinion about that also.
Well, hers was a very good closure, so is it good to, why mess with a good thing?
Well, you wouldn't mess with it. That's correct. If the bladder's inside and the bladder's growing, I would probably leave pretty much alone.
Okay, fine. That's great. Thank you for your answers. I appreciate it.
Yes, ma'am. My pleasure indeed.
Karen, thank you so much for joining us and participating with us tonight.
Thank you.
So, Pam, I am getting word from the boys in the back that we might have a little technical issue here. We're not getting any email flow. Are you getting emails?
I haven't looked. Is Jeffrey looking on Facebook to see if there's any emails? I do have questions that came in ahead of time.
Well,
that we could ask.
Sure. If you have any questions there, we can.
Yes. Let me.
We're just not getting any email feed, so I don't know what happened there, but.
Okay, but we do. Okay, so let me ask you this one. This is a gentleman from India. He said, "Hi, my son is from India, and the doctor here says that he would try by closing the bladder neck and then making an artificial urethra. What are the percentage of chances that this process can be successful? And I also want to know, are children with bladder exstrophy able to hold their stools?"
So, Pam, I think I saw that question, and you were kind enough to send that along earlier today. I think if he's going to tie the child's bladder neck off, he may be talking about a Mitrofanoff and as an access to the bladder, and he's just referring that to the parent as a urethra or access to the bladder. And the success rate of that is very good. I mean, certainly over 90%. There's really no problem with that. I think if the guy does a reasonable amount of reconstructive bladder surgery, then I think that could be fine. What we see in exstrophy kids more than inability to hold their stool is constipation, and it's because the pelvic floor is always trying to be tight to hold the urine in. Of course, what goes through the pelvic floor besides the urethra is the rectum. So certainly in our fairly large exstrophy practice, the big problem is constipation. And our senior nurse practitioner, Dr. Marlo Eldridge, she follows these children very carefully for bowel function. And yes, constipation can be an issue. And we feel that if a child has chronic constipation, at the end of the day, that can even affect bladder growth. So yes, you need to focus on constipation. Yes, it can be treated. And yes, it can possibly affect bladder growth.
That's excellent. You know, I did hear Dr. Marlo Eldridge give that presentation, and as most of you know, I have a daughter who's 10 years old with bladder exstrophy, and we have the poop graph on our bathroom wall. So before that time, I really didn't realize how important it was to manage and monitor a children's their stools. So that, I think, is a great tip for all of us parents out there, that we should be watching that closely.
Well, Pam, we're coming up on a close. Is there maybe another question that you have on your list that you think is a burning question we should get answered maybe before we let Dr. Gearhart go home for this evening?
Sure. You know, I have a question that's just for me, and questions as we as parents out in the bladder exstrophy community. I think, you know, my situation was different because I adopted a little girl with failed closures, but I can only imagine, such as yourself, Dr. Niezgoda, what families go through when they learn that they have a child with exstrophy. And I know it's hard to say, step back and take a deep breath, but are there a couple of questions, Dr. Gearhart, that parents should just step back, take a breath, and they should ask their medical team before they, you know, jump in 12 hours after birth, thinking that the closure is they need to just do this immediately?
Well, sure, it's not an emergency. If the baby's full term, good APGARs, nice bladder, your exstrophy team's ready, I have no problem with people closing them in the first couple of days of life, and I think that's fine. And I do that sometimes, but the situation has to be perfect. There's no urgency to this of running out to the operating room and closing this child. And I think there's some very valid questions parents can ask. Number one is, do you see many exstrophy patients? How many did you close last year? What were your results? How many of you closed in the last 5 years? What are your results? How do you follow these patients? Because certainly there are places around this country and the world where you can get an exstrophy team that's always there, always together. You don't have to put an exstrophy team together. The team's up and functioning to have your child's exstrophy closed. So I think certainly it's a very valid question. Is how many of these have you closed? How many did you do this year? How many did you do last year? Do you have a pediatric orthopedic surgeon that works with you hand in hand with this? I mean, do you have a pain control team that helps keep these babies still and keep them comfortable after surgery? All those are very valid questions that parents can ask because it is not a surgical emergency.
That's great. I think that is something that parents, again, and I think there's a fear and a shock factor, and I think we want to rush off and get it fixed. And so I think that's a really good word of advice, to just make sure that we have the right team compiled.
And I'll just echo those comments from a parent standpoint as well as a physician standpoint, and share with you a little of our story. You know, I think you know, everyone is shell-shocked. Jeffrey was not diagnosed prenatally, so it came as a surprise to us. And we were rushed off to a medical center soon after he was born, where the surgeon said that he was going to resect Jeffrey's bladder. And that just sort of came as a shock to me. And I knew enough to say, you know what, I'm not so sure this is right. And I asked that question. I said, how many of these children have you taken care of? And his answer was 2. And my answer to him was, Jeffrey's not going to be your 3rd. And so I did a little research and called some colleagues, as Dr. Gearhart mentioned, and we eventually found our way to Johns Hopkins. But I think it's very good advice to take a pause and to ask those questions, because again, you know, a center of excellence and getting to not only a surgeon but a team of clinicians that is well prepared to take care of your child, your baby, is paramount here. It really is. And the results are going to speak magnitudes for what you have to deal with for the rest of your lives. So I think those questions are important and should be asked. The other thing that I wanted to say about this is that once you do have you know, surgery at a center, I would encourage all parents to make themselves available to talk to those new parents that have been identified prenatally or even afterward as a resource. That can be very, very helpful in sort of passing the word as sort of some of these things. And obviously that's one of the reasons that the ABC was formed. Kathleen and I made that decision that we wanted to reach out and let parents know that they weren't alone. There was an organization there was to support them and be available to them and answer these kind of questions. And I can honestly say that, you know, our mission 25 years ago was to prevent some of these children from potentially being subjected to the same disastrous surgery that Jeffrey, you know, nearly avoided, and prevent them from having those disastrous results by getting them to centers of excellence. And I think the organization has done a good job, but much more needs to be done, and that's why we continue to do this, Pam, and that's why we're so thankful that you're in the driver's seat now. As I've started to get gray, I've sort of lost some of that energy, and I think that you know, having someone that is with your type of passion is really made has been just a great thing for the organization. So again, thank you very much.
Well, thank you, and thank you both. I don't know if there's any more questions or if we want to just kind of close this down tonight.
Yeah, we have nobody else on the line, so you know, why don't we do that? John, sure. You know, you said earlier, friendship. That's really true. You're Jeffrey's surgeon, but you've become a true friend of the family, and I want to thank you for all your care through the years and your continued support of the Bladder Exstrophy family.
Well, we never have our yearly Exstrophy picnic or any major Exstrophy meeting like the Exstrophy boot camp a couple weeks ago without having Pam come and beat the drum a little bit, because we think that helps make a difference too, Jeff.
Yeah, it really does.
Yeah, and thank you for including me and as part of your team up there. I enjoy working with all of you. I've learned a lot, and you know, I too am a parent, and just, you know, a word of hope out there. I did deal with a little girl with failed closure, and getting her to a center and having her have good quality care. She's thriving and is just really enjoying life. And so if you've had one failed closure, it doesn't mean that you can't go get to a center and work with someone like Dr. Gearhart and make sure that the next time it's done well and done right, and the children can thrive and be successful. It's not all lost. So
that's absolutely true.
So thank you both. In closing, I just want to once again encourage all of you to join us in Oklahoma City in July. The information is on the website. The parents that I'd really encourage to participate in this meeting are those that have newborns, those with children, you know, 1 and 2 years old. And the reason being is simply this. You have a lot of concerns in your mind as what your child future has in store, what they will be like. I worried that Jeffrey wouldn't be able to play ball with the other kids and run up and down the street on his bike. And that first picnic that we attended really answered all those questions, that he would be normal in many ways. I encourage you to come and see for yourselves that these kids have full lives ahead of them, full, healthy, productive, normal lives, if you will, taking bladder exstrophy on the side. So come join us in July. I guarantee you will not be sorry that you did. So once again, John, thank you so much for spending your evening with us here. Pam, you did a great job. And again, to the team in the back room, WebCME crew, thank you so much for making this possible.
Good night, everybody. Thanks so much. Nice to see you all.
Good night.
Good night.